started. Well, welcome to the 2025 PEP Summer Workshop. My name is Dr. Stacy Obeid, and I am your host for the afternoon with a super exciting topic that we have for you all today called the Neurobiology of Addiction in Adolescents and the Role of SBIRT. And so we have a few housekeeping slides that we'd like to go through with you first before I introduce our great speaker for today. So let me go to the next slide here. All right. So first and foremost, what we're going to take a little bit of time to do is, well, first, I love all of the introductions in the chat box, so that's great. So keep that up. Feel free to introduce yourselves in the chat box. But there is a sign-in link in the chat box as well. And so if you can take a few moments to do that, especially if you are someone who is seeking CME, CEUs for today, please take a few moments. I'll actually pause for a moment and give folks a chance to find that link and complete that. So I'll give folks a few moments to do that. Even if you're not seeking CEUs, we still like for you to fill that out just so we have a record of who's here with us, which is really important for us. So please fill that out, even if you're not seeking out CME credit. And so again, I'll pause for about 30 seconds before I continue. All right. So again, for those of you who are just joining, there should be a link in the chat box to sign in for CME CEU credit. We'll post that link periodically throughout the workshop just because we know when people sign into Zoom a little bit later, anything in the chat box, you won't see that. And so every a few moments, we'll throw that in the chat box for you so you can complete that as people come in. Also, towards the end of the talk, around 3:45, 3:50 is Central Time, we will post an evaluation link in the chat box. To receive CME or CEU credit, you do need to complete that. That's what we will go off of to then send you your lovely certificate via email. And so again, towards the end of the talk today, we'll post that link in the chat box for you to complete before we finish the workshop for today. This is the CME statement here, just letting you know you will get 2 hours of CME and or CEUs at the end of this activity. These are the disclosures. We will disclose any relationships that any of us have that will be discussed in the presentation if there are disclosures to report. All right, so before I hand the mic over to our fantastic speaker, I did want to briefly share with you all about what the PEP program is, in case you're wondering what is that? Why are we all here today? This is what's bringing us all together. So the PEP program stands for the Pitch Expanded Providers Program. This is a HRSA grant that myself and some of my wonderful colleagues from UTSA have the pleasure of being a part of for the past 4 years. This is a behavioral health workforce and education grant through HRSA that focuses on training behavioral health learners in various integrated care areas. And the focus of the grant for the past 4 years has been in pediatric behavioral health issues, hence our topic for today. And so as you see on the screen there are 4 disciplines that were part of this training grant. Were clinical mental health counseling students, school counseling students, and social work students, all from UTSA. And then we had psychology residents from UT Health San Antonio with the Long School of Medicine, doing a variety of trainings, as you see on the screen, interprofessional education workshops to essentially learn how to work together to provide better whole person care for all patients, but specifically our pediatric patients that have been the focus for this grant. So that QR code, in case you're really interested, and learn more about our program over the past 8 years, really, that we've been doing this. This QR code will take you to our website to learn more about the PEP program. This is our fantastic team. Many of them are in the Zoom room audience right now. So just want to give a shout out to Dr. Heather Trepal, who's been our fearless leader in this endeavor, Dr. Jessica Lloyd Hazlitt, who's the counseling track coordinator, myself, I'm faculty at UT Health San Antonio, and helped with the psychology track as well as our IPE work. Dr. Ian Johnson has been our social work track coordinator. Dr. Gretchen McLean has been our school counseling track coordinator. Our program evaluator, Dr. Mercedes Ingram, has been wonderful, is wonderful. And then our graduate research assistant, who is now Dr. Swathi Weaver, has been with us over the years as well. So as you can imagine, a project to this level is very much a team sport. And so I just want to give a shout out to our awesome team who put all of this on. So without further ado, I want to introduce you to our fantastic speaker. I want to read his bio to you because I don't want to miss anything about how awesome he is. So Dr. Mohammed Chaudhary is an adolescent addiction medicine physician and an assistant professor at Be Well, Texas with UT Health San Antonio. He received his medical education in Pakistan and completed a postdoctoral fellowship in public health and health services research at Brigham and Women's Hospital, affiliated with Harvard Medical School and the Harvard T.H. Chan School of Public Health. He then went to complete his clinical training in family medicine at WellSpan Health in Pennsylvania, followed by a clinical fellowship in adolescent addiction medicine. There are very few programs out there in this, so we're very fortunate to have him here. At Boston Children's Hospital, affiliated with Harvard Medical School. His clinical interests include the transition of care from pediatric to adult addiction services for transition-aged youth, and his academic interests include risk prediction models and evidence-based addiction policy. So without further ado, I'm going to stop sharing my slides and give the mic over to Dr. Chaudhary. Thank you, thank you.
Thank you so much, Dr. Obaid. I'm gonna try and share my screen, and I would like a thumbs up indicator from people if they can see the presentation. Anyone? Oh yeah, perfect, perfect. Awesome. Thank you so much for that lovely introduction, Dr. Obaid. Um, so today's talk is going to be divided up into two parts because it's technically speaking two different topics that I really wanted to talk about. One is the understanding of why do we care so much about adolescent addiction and how is it a different thing as compared to when we talk about addiction in general and how we've been treating addiction for the last couple of decades as primarily an adult problem, right? With primarily adult programs all across the US. So I wanted to change that perspective a little bit and show why teenagers are particularly at high risk of substance use disorders and how we can help them. And then the next topic that I really want to talk about is something that is really valuable to mental health professionals, primary care clinicians, as to what they can do to play their part in appropriately screening these individuals and triaging them, either providing them care right there and then, or triaging them to the right specialty services. So without further ado, just wanted to mention that I have no relevant financial disclosures regarding the content of this presentation. In the first part of the presentation, we will focus on describing the key aspects of adolescent brain development, exploring the neurobiology that underpins addiction vulnerability in our adolescents, highlight the impact of cannabis and alcohol on the on the adolescent brain, because these are one of the most used substances after nicotine, and then discuss the treatment options for cannabis and alcohol use disorder in the adolescents. The second part of the presentation is focused on defining what screening and brief interventions are and describe their role in the spectrum of substance use disorder. Where do they fit? Then summarize the key evidence that supports the effectiveness of screening and brief intervention across different populations and settings. Identify the core components of evidence-based brief interventions and demonstrate how to integrate these brief interventions and these screening tools into your routine medical or mental health care workflow. And finally, to recognize what are some of the barriers that we do face when we try to implement such programs, and how do we overcome these barriers to implement these programs. So we'll start off with part one. We'll take a small little break in between for anyone who wants to drink water or go to the bathroom, and we'll have some questions afterwards, and then we'll move on to part number two afterwards. So before we start anything, I really wanted all of us to be on the same page when we think about addiction, right? We are all from specialties and service lines that do deal with mental health and substance use disorder a lot. So we probably already know this definition of addiction, but I really wanted to make sure that we are like all thinking about the same thing when we talk about addiction. So what is addiction? It is a treatable chronic medical disease. These are two operative words here. It's treatable. It is a chronic medical disease. It's not good choices or bad choices, good parenting or bad parenting, right? Virtue or vice or anything like that. That involves a complex interaction among brain circuits, your genetics, the environment you live in, and your individual life experiences. And people with addiction to substances, they engage in behaviors that become compulsive and are they often continue despite their harmful consequences and despite them not wanting to do it, right? That's an important thing that I want everyone to understand. And so when we think about addiction, the first thing that comes to mind is that physical dependence on on a particular substance, right? And we use this term, like, most of us say, like, oh yeah, I'm addicted to coffee. And maybe it's like okay to use casually, but when we say addiction, it's not merely physical dependence we're talking about. It has to have three components to it. It has to have that physical dependence part. Yes, that's very important, right? Because that leads to that, like, boom and bust cycle, or that withdrawal cycle and that euphoria cycle that leads them to use again and again. But it also has to have some psychological maladaptive behaviors, right? Which includes maladaptive stress responses. Either every time you're stressed out, that's the only way you can find stress relief, by using the substance, or every time you want to feel better, you want to feel pleasure, that's the only way you can think of experiencing pleasure, by using the substances, or not getting the substance makes you anxious or depressed. So all of these are like psychological maladaptive behaviors. And the third thing that addiction should have, that when you're looking at addiction, is what we call psychosocial dysfunction, right? It is a dysfunction in the person's environment in which they're living in, right? It can be in the form of inability to maintain their livelihood or finances, inability to maintain their housing, inability to maintain their relationships, right? So all of these three things have to be there for it to be called an addiction, and we have to address all these three things mm, uh, all together, ideally, for us to expect sustained recovery from substances. So now, after we've talked about addiction, there are some ground rules I want everyone to have, right? And this is actually, I think, just good practice, and probably already everyone knows about it. It's more relevant to populations like, or professionals who've not dealt with this population before. But instead of using words that are incriminating in nature, like drug abuse or abuser or addict or junkie or alcoholic, use words that actually puts the person first, and in disease specific, like substance use disorder or an addiction, right? Or persons with substance use disorder rather than abusers, right? There is no clean drug test. There is no person who's clean, who's not using substance. They're just abstinent, right? because there is nothing dirty about using substances. So it's important actively using versus abstinent as opposed to dirty and clean. And then there are some specific terms like, for children born to mothers who have opioid use disorder and they're experiencing opioid withdrawals, it's called babies with neonatal abstinence syndrome. So it's like, person first and then the disease rather than like, some incriminating words that are associated with it. And one thing that we used to use even in the addiction circles was this word called medication assisted treatment. And that led to a lot of like, confusion sometimes and sometimes stigma that somehow these medications are like crutches that we give them. Right? And they don't really need those crutches. And like, they got the idea they need to be off these crutches in order to actually be in recovery. And as long as you're on any medications the doctor is prescribing, you're not really in recovery. And so that first of all, that's not true. And that's why we changed this word from medication assisted treatment to medications for addiction treatment, right? Because this is not a crutch we're using to give you the real treatment. This is part of the real treatment, right? These medications that the doctors prescribe for substance use disorders. So those are some ground rules. And now let's start off with a crash course on the development of an adolescent brain. So back in the days, like maybe 2 or 3 decades ago, we used to think that most of the brain development happens within the first 10 to 12 years of a person's life, and they achieve their peak brain development by the time they're 12 years of age. And this was thought because when we looked at like, the volume of the brain, we found out that, by the time someone is around 10 to 12 years of age, they have the adult volume of their brain, like whatever their adult volume of the brain is going to be, they achieve that volume by the time they're 10 or 12. And that was like, the neuroscientific understanding of brain development back in those days. But then we discovered something, what we call like microscopy, right? And we found out that neurons, even though the number of neurons doesn't change much, right? But what does happen is when a person is born, they have some connections between these different neurons, right? But as the person starts growing, there is almost this blossoming phase. It's in which there is a lot of proliferation of connections between different neurons. And by the time you're like, 6 years of age, you have a very dense network of connections between all these different neurons. And that's why sometimes we say that, the brain of like a child is like a sponge, it's there to absorb everything. And the reason for that is because there are all these connections all across these different neurons, right? So it allows for all these different possibilities of learning. Now, most of these connections are not very useful, but they're still there so that it's easy for the brain to learn. So a 6-year-old's brain is actually primed for learning, but it is not a very effective brain because there's a lot of redundant connections. There's a lot of connections that are there that are not used. Um, and then as you start growing further, what ends up happening is the brain starts realizing that connection X is not very useful. It's not used very often. So let's prune this off. Like just like, if any one of you is a gardener, they know they prune the branches that are growing in the wrong direction. And it actually helps the plant grow better. So in the same way, the brain realizes that these certain circuits are not being used very often and it gets pruned. So anything that's not used is getting pruned, and things that are getting used, they are strengthened. So over time, this pruning process happens. And if you see like, the brain at 14 years of age, it's actually less dense in terms of connections as compared to a 6-year-old brain. And this pruning process keeps on happening. And this makes the brain more efficient, right? It takes less energy to run the same brain, right? And then eventually, when the brain thinks that this is the adult form that we want the brain to be like, that the final process of development happens, which we called myelination, but in simple terms, it's just insulation, right? So it's like when it knows that the electrical circuitry is all there that we need for an efficient a well-trained brain, what the brain does is it applies a layer of insulation across all these connections so that they become protected, right? This process is called myelination. And all this process is completed around the age of mid-20s. So way later than what we initially thought it was, like, not 10 year or 12 years of age, but actually in your mid-20s. And then we found some, we had a new method of learning about, like, how do you look at brain development? And and this was called PET MRIs, right? Or functional MRIs. These MRIs look at the functioning of the brain or the metabolism that's happening inside the brain, right? So the parts of the brain that are still under construction or they're still developing or still under development, they are going to be metabolically more active, right? And that's where you'll see the hotter colors, so the reds and the yellows and the greens. And the parts of the brain that are completely developed now, they're going to be metabolically less active and they're going to be more bluer in their shades. So if you look at the brain as it develops, and this graph basically shows your brain from the ages of 5 up until the age of 20, you see that the brain continuously keeps on developing and turning blue as it grows, right? But what we notice here is that not all parts of the brain they develop simultaneously. So it's not like the whole brain was a shade of red and then it turned a shade of yellow and it turned a shade of green and then it turned a shade of blue. It's actually different parts of the brain are actually maturing at different ages. And that's very important to learn here, because that's going to take us to the next point. If we look at different parts of the brain and how they develop, the first part of the brain that actually develops is called the cerebellum. This is the um, balance center of your brain. So this provides you with coordination and balance. And that's why you see that, these small little toddlers, they start waddling around at the time of 1 or 15 months of age, 1 year of age or 15 months of age. And then all of a sudden, when they're 2 or 2.5 years of age, they run like adults all of a sudden. That's because their cerebellum has completely developed and they've achieved how to maintain balance. So that's the first part of the brain that matures, and that matures around 2 to 3 years of age. And then comes the terrible twos, right? Or the terrific twos, right? Or the amazing twos. So this is the time when the amygdala, or the part of the brain that is responsible for understanding emotions or processing emotions, that's developing, right? So kids all of a sudden experience these new emotions that they have not experienced before, and they don't know what to make of them. So it's not like they're crying, they just don't know what to make of their emotions. And that's just like the expression of those emotions comes in the forms of tantrums, and they throw these tantrums, and that's because their amygdala is developing. And by the time you're around 4 to 6 years of age, the amygdala has developed and they start to learn some emotional control. And the next part of the brain that develops afterwards, after like close to the age of like 6 and then onwards, up until the age of 14, that's called nucleus accumbens. That's the part of the brain that is responsible for pleasure sensations, right? It's for experiencing pleasure, and it is also for seeking pleasure, right? Or pleasure salience. And this part of the brain develops completely by the time you're 14. And what ends up happening is, by the time you are 14, you're a teenager, the pleasure center of your brain is completely developed. So you can experience pleasure the same way an adult can. Actually, by some accounts, they have more dopamine receptors in their pleasure center. So they actually experience pleasure more than adults do, right? But the part of the brain that's responsible for risk management, or which are the brakes of your brain, right? That's still not developed, because that's the prefrontal cortex, and the maturation of the prefrontal cortex happens somewhere in the mid-20s. So teenagers are in this weird spot where their nucleus accumbens, which is the pleasure center, has completely developed. But the prefrontal cortex, the part of the brain that's responsible for telling them this includes risk, you better think about it before, right? That's not yet developed. And they sit in this weird part where they are all gas, no brakes, and that's why teenagers are a little more hedonistic than adults. Now, the question is, why would nature make it so, right? It doesn't seem like good design, but it actually is, because you want the teenagers to experience new ways of survival, to learn new ways, to seek out new ways of seeking pleasure, or for that matter, survival, right? And that helps the species grow, or that helps the species survive in a changing environment, right? So teenagers over the years have not changed. So they're the same that they were like 1,000 years ago, that they are right now. What has changed is the landscape of available substances to them, right? And that's why we're more concerned about it at this time than we were, like, 100 years ago. Another important thing to remember here is that this was a study that was done, which basically what it shows is that there are two types of rewards, right? There is a Pavlovian reward where the reward is associated with an unrelated association. So, the Pavlov's dogs, where Pavlov was a scientist who trained his dogs to salivate at the sound of a ringing bell, because he always rang the bell before he gave them food. So the dogs involuntarily formed this association in their brain that, the ringing bell means food, and they salivate at that time, right? So that's called like they just associate reward with an unrelated stimulus. And the other is operant conditioning, in which you get a reward after you do something to earn that reward, right? That's like, your that's like, a parent rewarding their kids with, like, some privilege, like a video game for getting good scores in good grades at school or something like that, right? So when they looked at it in terms of brain activation, uh, adults respond both to Pavlovian rewards, which means like rewards they get by forming association with unrelated stimuli, and also to rewards they get for certain behaviors. But when they looked at adolescents, which is the orange bars here if you can see my pointer here, the orange bars, what they saw was that in Pavlovian conditions, in conditions when there was this unrelated or effortless reward that was being given to them, they showed more brain activation. And they had almost little to no activation in the case of operant rewards, or rewards that were associated with certain kind of like prerequisite behavior from them. So what that basically shows that teenagers are looking for effortless reward more than adults are, as compared to a reward that requires some effort. And substances are those feel good chemicals that give you effortless reward or effortless pleasure. And then one thing to keep in mind is that we talk about all these different substances, they have all these different receptors they act on, and all these receptors are like, distributed in the brain in different parts of the brain. But eventually, all the addiction pathways, they run through this part of the brain, which is called the nucleus accumbens. And as I talked about, this is the pleasure center of the brain. So all these chemicals, either directly like methamphetamine or nicotine or cocaine like stimulants, or indirectly like heroin or alcohol or marijuana, they stimulate the nucleus accumbens, and they lead to the release of dopamine, which is a feel good chemical. And that's where the addiction cycle actually starts. And based on their brain development, teenagers have a developed nucleus accumbens and not a developed prefrontal cortex, which is the reward center, and that's why they are primed to use substances. And this can be actually seen in this survey. This is called Monitoring the Future study. This is a long-term study carried out by the University of Michigan. They've been doing it for many number of years now, and they do a survey-based study on school-going kids. And what they wanted to look at was what was the time of initiation of any substance in these kids. And if we look at it for the 12th graders, which is the red dotted line, um, almost 40%, based on the most recent estimates, almost 40% of all teenagers have used some substance by the time they're in their 12th grade. Yeah, which is an astounding number actually. And even though these numbers have been improving over the years, and especially during COVID times, these numbers like sharply, and we thought this might just be because now kids are being homeschooled and this survey is being administered at school, so they might be a little more cautious in answering these questions. But that turned out not to be true. It turned out that spending more time home with the parents was a protective factor against the use of substances, and that led to that decrease. But yes, it's still pretty high, 40%. So by this graph, I really wanted to impress upon everyone that substance use disorder or addiction is not an adult problem. It is a pediatric problem. It's just that we don't end up treating it in the pediatric age group and we let it fester. And by the time we treat it, most of the things that we're trying to do are just harm reduction as opposed to actually trying to achieve full functional recovery in these individuals. And it's very important to identify these at-risk individuals early and start treating them early. So now let's talk about some of the more use intoxicating substances in the teenage age group, cannabis and alcohol, and how it differs, like, how the impact of cannabis and alcohol differs on adolescents as compared to adults. So first of all, let's talk about cannabis. So cannabis is a naturally derived plant product. It can be consumed in the form of directly in the form of the flowers or the buds of the plant, or it can be consumed in the form of concentrates in the form of oils or now vapes and even concentrates like butter, like THC butters and stuff like that. There's like so many products of like THC now that it's difficult to keep a track of them anymore. And then edibles are always there, yes. So these are the different forms of cannabis. But what I want you guys to all understand is that if you look at this purple molecule right here, that's a THC molecule. And that's the thing that you consume. That's the psychoactive chemical in cannabis or marijuana or weed, whatever you want to call that. And if you compare that to anandamide, this is the naturally occurring molecule inside the brain. And we'll talk about what the purpose of this molecule is a little later, but like this is the naturally occurring, the green molecule is the naturally occurring anandamide molecule. And if you look at it, they have remarkable structural similarities. So they look the same, they try to act on the same receptors. Now I'll talk about what anandamide is and what it's there for. We talked earlier about the brain development, and I said something about the pruning of these synaptic connections, right? And the pruning was dependent on which of these pathways were used often versus which of these were not used. Anandamide is a chemical that's like a volume down switch of the brain. So let's say I am a neuron and I have a synapse from another neuron at my shoulder. Like, they're tapping me with an impulse, right? And they start tapping like really fast and I get annoyed, like really annoyed. I'm like, what are you doing? I don't need that tap, And so I tell that neuron behind me that you need to quiet down a little bit, not that much tapping. So I release that anandamide to act on that neuron for it to quiet down a little bit, right? So it's like a volume down switch that gets released that gets released locally to quiet down neurons when they become too activated. Um, and THC, because it's structurally so similar, it acts on the same receptors as an anandamide. But what are the differences now? If you look at it, anandamide is like almost only a half as potent as THC. So this is like a stronger version of anandamide. THC is a stronger version of anandamide. And the other difference that I said is like anandamide is only released locally. Wherever there's a lot of activity going and it needs to be calmed down, that's where anandamide is released. Or when you consume THC, being fat soluble, it actually crosses the blood-brain barrier and it acts on the whole brain all together, right? So it's like a global volume down switch for your brain. So, and when some part of the brain is quiet for too long, what ends up happening in an adolescent brain, as we talked about, pruning happens, right? So that part of the brain gets like pruned down because that's not being used, right? So a part of the brain that was super active but didn't need to be active, and anandamide is released there, it quiets down that part, and then if it remains quiet for a while, that part of that connection is pruned away. But when you consume THC, It's acting globally all over the brain and it's quieting down the whole brain. And now the brain doesn't know what part to prune and what not to prune. And it starts pruning a lot of it that shouldn't be pruned away, right? And so anandamide is like a scalpel that acts regionally in parts of the brain that needs to be pruned away, whereas THC is like a sledgehammer. It's like, acting globally on the whole brain and getting all parts of the brain pruned away. And that's why over time, and these are different circuitries that I really wanted to show before actually I talk about like how does anandamide changes the brain, how does THC change the brain long term. But this is the serotonin pathway. I just want you to spatially remember where the serotonin pathway is in the brain, right? It's controlling your mood, it's controlling your memory and your sleep and your cognition. That's what the serotonin pathway does. And this is the dopamine pathway or the reward pathway. So it kind of sort of controls motivation, controls euphoria. It also controls some motor functions and compulsions. So I want you to remember spatially where in the brain that is. And now, after both these slides, I'm going to actually show you where the the cannabinoid receptors are in the brain, where THC works. It's pretty much everywhere, actually. So it acts both on the serotonin system and on the dopamine system. And it kind of sort of messes with both these systems. And what does this messing looks like? So it impacts your sensations, the red part of the brain right here, because it has the yellow dots are all the cannabis receptors or THC receptors, right? So it works on sensations, it works on your movement, impairs your movements, it impairs your judgment, impairs the reward pathway, or like, makes you feel like euphoria. It impairs your memory, it impairs your coordination, and vision is the only part where you don't find a lot of like, like endocannabinoid receptors. So not much impact on your vision. So it pretty much impacts the whole brain. And what does it do? So there was this study that shows that persistent cannabis use leads to neuropsychological decline if used in the childhood. And I'm going to actually talk about this study a little bit. So what they did was they looked at individuals and they followed them up long term, and they looked at them pre-initiation of cannabis use and down to 13 years of age. And then they kept following them up, and and measuring their IQs over time. And what they found out in this study was that compared to people who never used cannabis, people who used cannabis for 3 years or longer had a significant decrease in their IQ. So that's one major finding. Not only did their IQ not increase over time, but there was a significant decrease in their IQ for people with at least 3 years plus of cannabis use. The second part, which is actually not depicted in the graph here, which was another figure in this study, which showed that this decrease was larger the earlier this use was. So if your use was, let's say, between 17 to 20, this decrease would have been smaller as compared to if your use was between 13 and 16 years of age. So the earlier you initiate using, the higher the impact on your IQ would be from cannabis use. So that's one impact of cannabis that we should be aware of. This is the other thing that I really wanted you to show. So here in the picture, what you see, the colors over here, they are from an fMRI or like a functional MRI, which shows like the function of the brain as compared to the structure of the brain. And the part that is colored is the part of the brain that's called the corpus callosum. It is a bridge between the two hemispheres of the brain. And good communication between the two hemispheres of the brain is important or crucial for cognition, right? So on your left hand side, you can see a healthy non-user, and on your right hand side, you can see a person who uses cannabis or marijuana on a regular basis. Uh, does anyone want to take a guess? Like, what's the difference between these two? Or like, does can anyone see a difference? Okay, you can unmute your mic and say something if you want to.
There's more white than gray.
Yeah. So white and gray is not important. Like that's the anatomical picture in the background because I wanted to make sure that, we're looking at the same things. Only the colored parts are important because they are showing the function of the brain, right?
Yeah.
Less
So there's a
blue.
decrease. Yeah, there's a
Red and
decrease.
yellow.
Mhm.
Yeah. Yeah, good, good, good. Whoever said red and yellow. So you
Less
see there is
blue.
actually thinning of the red and yellow part. So yes, anatomically, the corpus callosum might look the same, but functionally it's now limited, right? So the yellow and the red parts are thinned out. And a picture that I should have actually put up here is that if I were to put a fMRI picture of a person with schizophrenia, it would actually match very closely with the person who is a daily cannabis user. Because in schizophrenia, also, we see this thinning of the corpus callosum or the bridge between the two hemispheres. Because as I said, this bridge or this communication channel between the two hemispheres is important for cognition. So cognitive disorders like, schizophrenia and bipolar disorders, they show that there is some thinning of this bridge between the two hemispheres of the brain. And so that is why we see that a meta-analysis, which is a study of studies, which looks at all the evidence on a particular topic and then collates into one uh, uh, um, um, one outcome. And what they found out was that people who use cannabis on a regular basis, they were almost twice as likely to develop a psychotic disorder, right? Psychotic disorders are bipolar disorders, schizophrenia, schizoaffective disorders, all these disorders that actually mess with your cognition, right? So they are twice as likely to develop a psychotic disorder. Again, another study, and this is a one-off study, so I wouldn't want you to like base your numbers off of it. But again, what it shows is that people who use cannabis like 50 times or more, which they defined as like chronic users, they almost had like a sevenfold increase in their likelihood of developing a schizoaffective disorder, right? I mean, again, this is not the general population. This might be like an at-risk population to begin with. But again, sevenfold increase means that, either cannabis is directly implicated. We can't say that there is causation, but there is strong enough an association that we can say that either there is direct link between like a psychotic disorder and cannabis, or it at least potentiates the emergence of psychotic disorders in at-risk individuals. And then the other thing that I want everyone to know is that when we talk about cannabis, and then especially like, the people like me in the group who are a little older, they think of cannabis differently, right? They think about, oh yeah, my grandpa used to do cannabis, no big deal. Well, the thing is that just cannabis, I'm talking about no modified forms, I'm talking about the actual, like, the buds and the flowers. Over time, the breeders have selectively bred them so that the amount of the psychoactive chemical in there, the THC amount, which is the actual psychoactive, like, drug in there, that has increased from a mere 4% to the latest, in this figure shows up until 2019, and it was up to 14.3%. But I saw a figure from 2022 or 2023, which was up to 16% now. So the amount of psychoactive chemical in the same, like, cannabis blunt that you're using went up from 4%, close to 4%, to up to 16% now. That's a major jump, major escalation. So it's not the same drug that like, your grandpa used to do. And the other chemical in cannabis is CBD or cannabidiol. It's supposed to be a protective chemical in nature. It's a little mellowing in nature, and it takes away some of the edge from the THC. And if you look at it, the amount of CBD in cannabis has not changed over the years, right? So it's the same amount of CBD, but like almost five-folds more THC in the same cannabis, right? So it's not the same drug anymore. And then when you talk about the cannabis vapes and the cannabis cartridges, they are close to like 90 or 95% THC. They're just a completely different like drug altogether. So it's not the same drug when you think about like cannabis from the old days. And so cannabis in a study showed that like 27% of adolescents, they experience some form of hallucinations. Almost a third of them experience some form of paranoia or anxiety, and almost like 40 to 45% experience like either of the psychotic symptoms when they are on cannabis. And then one of the dreaded consequences of chronic use of cannabis is the cannabinoid hyperemesis syndrome. It used to be called the cyclical vomiting syndrome. And this is a weird one because it's not directly associated with you smoking cannabis at that time. It's just once you chronically start using cannabis, you have these episodic bouts of nausea and retching and vomiting, and none of the antiemetics seem to work on it like very effectively. The only thing that these people will report works for them is like a warm shower. And the reason for that is because it's because of cannabis impacting a certain receptor in your brain that is heat sensitive. So warm showers tend to help, and then some antipsychotic medications on in the inpatient setting sometimes help. That's called haloperidol. But most of the times, like you won't be able to get rid of it, and it's going to be episodic in nature and not directly associated with you doing cannabis at that time. So it's not like when you do cannabis you have that, right? When you stop using cannabis, the frequency of these bouts, they reduce, and over time they go away when the cannabis is cleared off from your system. And then other long-term consequences of chronic cannabis use include worse problem-solving skills, less control over your emotions, slower processing, lower verbal acuity, and poorer memory. So these are all associated with chronic use of cannabis. And the reason, as I said, is because THC is like a global volume down switch on your brain, and the adolescent brain is looking for places in the brain to prune. And because there's global volume down, tries to non-selectively prune the brain, and that's why you have all these consequences. And then people will ask you about CBD, because I just said it's psychoprotective in nature, so maybe I should use CBD, doc, or or they'll ask their therapist, is it fine for me to use CBD at least because that's natural, it has all these benefits, should I use that? Um, and the answer, and so is CBD safe? The answer to that is, if you're asking a scientific question, is CBD a good thing, right? There are studies that do show that there are benefits to using CBD, right? And there are actually FDA approved medications that are CBD, like there are pure CBD products that are used for some specific type of epilepsies or like seizure disorders, right? But when you say CBD, you mean the CBD that's available in the market. And actually, they did a study on that. And what they found out was, first of all the CBD products that they tested from the market, all of them had some amount of THC in there. So it's not like pure CBD. You still have that psychoactive compound in there. And if you are an at-risk individual who has a family history of psychotic disorders, it might just be that trigger that you need to actually go into full-blown schizophrenia, bipolar disorder, right? So that's one thing. Number two thing, no matter what the label on there says, it's 20 milligrams or 200 milligrams, the labels and actually the quantity of THC had no correlation in that study. So they stick on a label, but because there is no regulation, sometimes the CBD products they tested had no CBD in there, and sometimes it had 10 folds the CBD that it was listed on there. So again, the CBD that's available on the market, you cannot make like a definitive statement about that. But if you ask about theoretically CBD, yes, there are some use cases for CBD, anxiety, insomnia, and some epileptic disorders that it's really helpful for. But those are FDA approved products, super expensive, prescription only, that you can't get from your local vape shop. Now, moving on to the next thing, which is alcohol. And this is one of the oldest known mind-altering chemical known to humans. And it's produced by fermenting plant products, and it rapidly gets absorbed in your bloodstream, and it has impact all across your body. But one impact that I really wanted to talk about is actually the alcohol's toxic impact on the hippocampus, right? The hippocampus is especially sensitive to the effects of alcohol. And this is the part of the brain that's important for forming memories and for regulating your sleep. And this is the part of the brain that's getting developed during your childhood and adolescence. So again, I'm going to talk about an fMRI study again. This talk is like filled with fMRI studies because this is the shiny new tool we have these days. And fMRIs are like functional MRIs, which means it shows the function of the brain rather than the structure of the brain. So it's like very fascinating, like, to take a peek into the brain and how it works. So in this study, so there was this study that they did, and it had people do two tasks. The first task that they had was they just needed to focus on the screen. So it doesn't matter what's showing up on the screen. They just needed to focus on the screen. And the second task was to identify if they saw a pattern on the same part of the screen, not the same pattern, but on the same part of the screen. Like if they saw a pattern twice on the same part of the screen, they had to identify that. So basically, it was trying to test out their spatial memory, right? And they took all these different individuals in there, and they took non-drinkers and heavy drinkers into this study. So in this first example that I'm going to show you now is 16-year-olds with at least 2 years history of heavy drinking, and they performed the same tasks. And what do we see here? This is a non-drinker and this is a heavy drinker. So the reason for doing non-drinker was to see what parts of the brain should light up at that time, right? So you see that there are certain parts of the brain, especially in your visual center, which is the back of the brain, right, that are lighting up in red right over here, right? Uh, and then you see similar parts of the brain are actually lighting up in people who use alcohol heavily, right? So there's nothing wrong. But there is something wrong. If you look at the intensity of this lighting up, there's actually the heavy drinkers are lighting them up like more than the people who don't use any alcohol. And the reason for that we think is because that part of the brain has taken some damage, and then over time, like your brain is trying to compensate for that by overactivating those parts of the brain, right? They repeated that study in people who are a little older than that. So a little older, 20 years of age, and now 5 years history of like, heavy drinking. So back, we looked at 16-year-olds with 2 year history. Now we're looking at 20 years old with at least 5 year history of heavy drinking. And now it's completely different. The parts of the brain that are lighting up, just for reference, in non-drinkers, you see there's little to no activation in heavy drinkers anymore, right? So it means that whatever damage that alcohol had caused, at that point, the brain couldn't compensate for it anymore with like 5 years of heavy drinking. So then it just goes on to show that there is this incremental damage that's happening to your brain over time from alcohol consumption. And yes, initially you might not see any change because the brain is trying to compensate for that. And then all of a sudden, when it goes beyond the capacity of the brain to compensate, and you might see like almost like falling off a cliff right away, right? So that's what we see in this study. And so in adolescents with a history of heavy alcohol use, they had a reduced hippocampal volume. Hippocampus was a part of the brain that we talked about, right? With processing memories. So there was a loss of almost 10 to 35% of their hippocampus volume, reduced activity during memory tasks, and like, effects may be permanent if you continue using alcohol heavily. So the second thing I want to discuss is that, when we talk about the intoxicating effects of alcohol, we just assume like it's the same for adults and teenagers, and it's actually not. Adolescents are actually, so they did this study on rats, which showed that adolescent rats are actually less sensitive to the sedative effects of alcohol. So they do get the same intoxication and the same impairment, but they don't get the same like level of sedation from alcohol. So while adult mice or rats, when they were given alcohol, they slept afterwards. Like adolescent mice danced afterwards. Like we basically had more movements. Basically, what that shows you is that the level of impairment is same, but because there is more activity in adolescents while they're impaired as compared to adults, there is more chances of getting hurt. So they again did this experiment where they had like two different platforms in a bed of water, and they released like they put a mouse there, and then that platform disappeared, and the mouse had to find, or mouse or rat had to find its way to the other platform, right? And they looked at adult mice and they looked at adolescent mice. And what they found out was that adults who had no alcohol, they had fast responses, and adolescents who had no alcohol also had fast responses, which shows that the activation was there, right? But when they were on alcohol, the adults had like slow responses, or their swimming speed was slow, but the adolescents, their swimming speed was fast, which means it was not sedating them, it was not deactivating for them. Actually, it was activating for them. But when we look at the impairment or coordination, or the time it took them to reach the other pedestal, it was actually slow in both the adults and teenage mice, or young mice, right? What that goes on to show is that teenagers are similarly impaired, even though they're not slurring, they are not sleepy, they're not blacking out as often as adults, but they're impaired to the same amount, but they are more activated, which means more activity while they're impaired, which means more chances of getting hurt, more chances of being in situations where they can get physically hurt. So that's the different effect of alcohol on teenagers as compared to adolescents. So the summary is: damage to the hippocampus causes effects on your memory, and it is associated with addiction. Increased social stimulatory effects, which is actually the same, like, you have social stimulation both in adults and in teenagers from alcohol. But teenagers have increased physical activation from alcohol, which is different from adults who have sedation from it. And then the decreased coordination is there. It's the same in adults and in teenagers. So teenagers on alcohol are more in danger as compared to adults on alcohol. And this is the other important thing that I really wanted everyone to see, is that the first time you consume a certain substance has a lot to do with what your long-term trajectory with that substance is going to look like. And that's why we have a legal drinking age, and now we have a legal smoking age for cannabis, right? Because people, this association is very pronounced in alcohol, but it still holds true somewhat for cannabis, where if you have your first drink at the age of 13 or below, you're almost like, you have a 50% chance. You have like almost like a coin flip chance of becoming an alcoholic, or like a person with alcohol use disorder later in life. As compared to if your first drink is after the age of 21, that chance is decreased down to, down to only 9%. And the same thing holds true for cannabis, where if your first experience with cannabis is before the age of 13, you have a 20% chance of developing a cannabis use disorder, as compared to if your first use is after 21, there's only a 4% chance. So the longer we can delay their first use, the better it is for them in terms of their long-term chances of developing a use disorder with that substance. Now, we've talked a lot about like the differential impact of these substances on teenagers, but let's talk a little bit about what does treatment looks like. So this is like, the analogy of an iceberg. The part of the iceberg that's above water, uh, that's the part that needs to be done by pretty much everyone. It needs to be done by the pediatricians, the family medicine docs, all the primary care providers. It needs to be done by mental health therapists who are not responsible for substance use disorder treatment, but are seeing these individuals for for other concerns like anxiety, depression, all sorts of other things, right? And so brief intervention, or like screening and brief intervention, is something that everyone needs to do. And then if someone needs specialized care, we have a lot of other things, which includes like, integrated specialized programs like that includes behavioral contracting, including parents into the decision making, some medications that we can give for withdrawal management, counseling and support that is directed towards substance use particularly. We have medications we can give to people for preventing their cravings, and we do regular drug testing, not just for just looking at their drug levels and not like a probation officer, but to introduce some structure into their routine, and then some education and regular follow-ups. And to talk a little bit about like specifically about medications. So when it comes to cannabis use disorder, one of the medication that is super effective is called N-acetylcysteine, or NAC, simply NAC. This is a medication that is actually sold over the counter as a food supplement, and it's sold as an antioxidant. So it's like pomegranate juice. And it actually is, right? So it is an antioxidant. We do use it in the hospitals as well. When someone has some liver damage, we use it in the form of IV to reverse some liver damage. But for some reason, in the teenage brain, it has shown to decrease the withdrawals associated with cannabis and the cravings associated with cannabis. And this is very important because the withdrawals associated with cannabis are a little tricky. It's not like nicotine. It's not like 6 hours later you start feeling like you're constipated or you're like, edgy. For the first week, you won't experience anything when you stop using cannabis, and you're like, oh, people talk about these withdrawals, and I have none of those, right? So I've conquered that peak already. But then week 2 onwards, you start experiencing some withdrawal. Week 3 is when you peak on your withdrawals, and that's the time when most of the people actually start using again. They're like, I proved to you that I can stay away from cannabis for 2 weeks or 3 weeks, and I'm starting again because I choose to do it again. But that's not the reason. The reason is because that they are now at the peak of their withdrawal, when they are insomniac, when they have anxiety associated with not using the cannabis anymore. And so N-acetylcysteine, or NAC, actually significantly helps with that. It has little to no interactions with other medications. 1200 milligrams twice a day is what we recommend it at. And I personally believe it should be added to the water supply. I'm just kidding, but it is a very good medication with little to no side effects, and needs to be prescribed more widely, even by the primary care providers. The other medication that sometimes can be used, and it is more helpful in individuals who are a little older, because NAC works better the younger you are. So as you come closer to your late teens, it becomes less and less effective. So if you're like 17, 18 years of age, NAC will have little effect, if any. So in those situations, if you still need some medication to deal with the withdrawals associated with cannabis, we do give them gabapentin. Gabapentin is an anxiety medication and has a bunch of other uses as well. And it seems to be effective in taking care of the withdrawals associated with cannabis. Now, coming down to alcohol. For alcohol, the number one medication recommendation for alcohol cravings is naltrexone. This is not for alcohol withdrawal. Alcohol withdrawal is not something that should be determined if you should manage it outpatient or inpatient on your own. Some physician input should be in there, because cannabis withdrawals can be horrible, but alcohol withdrawals can be deadly, right? Alcohol withdrawal can kill you. So it is very important to predict the risk of severe withdrawal in someone. And if they are at risk of severe withdrawal, they need to do their detox. They need to do their withdrawal in a managed setting, like in a detox center or in the inpatient setting. So I'm only going to be talking about what you can give for alcohol cravings, and naltrexone is one of those medications that you can give for alcohol cravings. It is actually so effective that it works even if you don't want to quit alcohol. If you're like not even motivated, it still works. It actually works as a blocker for opioids. And the question comes in, why are you giving someone a blocker for opioids, when they have a problem with alcohol? And the reason for that is, inside your brain, the pleasure currency, or like the currency for experiencing pleasure, is something called endorphins. Those are endogenously formed opioids. So opioids are the pleasure currency of the brain. So if you block them, they stop having the same pleasurable sensations that they get from alcohol. Then over time, their brain rewires that they're not getting the thing that they needed from alcohol, and they stop. They decrease their drinking, right? So it's supposed to be one of the most effective medications against alcohol. If for some reason you cannot give someone naltrexone, and there are certain reasons you cannot give people naltrexone, for example, they are on opioids for some pain control, right? Or they have liver damage to a significant level. Like, you have to have very significant liver damage for you to not consider naltrexone. So if you have that, you can't give them naltrexone. The second option is a camprosate. This is a little tricky because it is effective, but the regimen for giving it is like super cumbersome. So it's like two big capsules, like 3 times a day. So you have to first of all remember to take it 3 times a day. Second, like it's like two big capsules. People don't like taking like big medications, and even though it is effective, but the regimen makes it a little less like practicable for these people who have less structure in their life to begin with. Um, you're gonna ask me how does a camprosate work, and my answer to you is going to be I don't know, but it works. Gabapentin is another medication. It does decrease some cravings, but it's not really there for cravings. It does help with mild withdrawal. So if you do not expect someone to have complicated withdrawals from alcohol, you can give them gabapentin, and it does help them with regulating their withdrawals in the outpatient setting. Those were the medications, and those were dealing with the physical dependence from the substances. But as we talked about it, addiction has the physical component to it, but it also has the psychological component to it. And for the psychological component, one of the therapies that everyone should know how to do, including PCPs, including therapists who are not even dealing with substance use, is motivational enhancement therapy. Like, and simply put, motivational enhancement therapy is trying not to introduce a new idea into someone's brain, is just trying to find an idea within their brain that points them towards abstinence or reduced use. So trying to find a motivation within themselves, and then over time solidifying that motivation or enhancing that motivation, right? And one of the key principles for motivational interviewing is do not, like, if you encounter any resistance from the patient, that means you're already pushed too far. Like, so you gotta like roll with the resistance. If you encounter like resistance, like you move to a different topic that's a little less uh, uh, um, scandalizing for the patient, right? So motivational enhancement therapy is number one. But then for some select people, you do need cognitive behavioral therapy. You need DBT or dialectical behavioral therapy. Um, Contingency management is one thing that actually helps, that works really well for substance use, but it's very difficult to actually operationalize. So contingency management is almost like operant conditioning, which means that every time you do a positive thing, you get a positive reward, which means if you have a negative drug test, you get money for that. If you show up for your like group therapy on time, like 1 week in a row or 2 weeks in a row, you get some monetary reward for that. So it has been proven to be very effective, and especially for substances for which we don't have good medications for, like stimulants like cocaine and meth and all these things. It's been proven to be super effective for these things, but it's difficult to operationalize because of budgeting constraints, and like how do you have these regular appointments, and the reward has to be closely linked to the desired behavior. It's not like you had a negative drug test and then you're going to get the money like 30 days down the line. You have to get it like instantaneously, right? It's like tricking your brain into getting reward from that good behavior as opposed to finding that reward in substances. So it is an effective method, but it is difficult to operationalize most of the times. And then family in adolescence, specifically in adolescence, this is one level of support that we have that we don't have in adults. In adults, they tell you they don't want treatment. You say them, "C'est la vie," like, I can't do anything because you have agency, you have autonomy, you can choose not to get treatment if you don't want to. But in the case of teenagers, the levels of control are still with the parents. So you have this additional support structure with you that's like working with you. So please utilize that for anyone who's less than 18. Uh, the 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 power of decision making, healthcare decision making, actually lies with the parents to begin with. So that's something you should definitely utilize. Family-based therapy can sometimes be helpful because family-based therapy addresses some of the family dynamic dysfunctions that are in place that are sometimes leading to oppositional behavior and then subsequently leading to substance use. At other times, it's more an exercise of like teaching the parents as to how to make this a non-punitive, non-judgmental, non-stigmatizing how to create a non-stigmatizing environment in the house, right? Because again, parents are not educated in this thing. You need to tell them that, substance use is not a virtue or vice issue. It was not your bad parenting. It was not bad choices on part of your kid. It is more an issue. It's a chronic disease that was probably because of some bad genetics, some bad brain circuitry, some life experiences, some home environment stuff. And that's the first thing. And then you tell them ways on how they can add structure to their teenagers routines at home, because they're only coming to you in the therapist office or in the clinic for like half an hour, 1 hour, maybe once a week at most, right? But they are at their homes 24/7. So if the home environment is not fixed, most of these things cannot be properly addressed. And then there are some levels of community support. So AANA, not as useful in like teenagers, but like smart recovery is one of those things that has been super effective in teenagers. And smart recovery is still group-based treatment, but it is not group therapy, and it is not the 12-step process, right? So it is a recovery stream that focuses on self-reliance and like, uh, enhancing the motivation through self-reliance. So that's super effective. And there are some virtual options out there that are nationwide that you can use for these kids if you can't form if you can't find local smart recovery groups. Peer coaching or peer support is something that's always effective in substance use disorder. And then, yes, for the most complicated of cases, we want them to be seen at an addiction medicine specialist. But for the vast majority of cases, they can be addressed in the primary care setting or in the mental health care setting through the therapist or their psychiatrist. But for those select few that you feel like they need specialized evaluation or specialized care, um, here in San Antonio, we have this program that we created, which is an integrated adolescent substance use program, which includes medical management. It includes parental support, parental guidance, and family therapy. It includes therapy for the individuals. It also includes like management of co-occurring disorders. And it's an integrated program so that parents and teenagers, they find everything all in one spot, because most of the times these individuals that will especially with like serious substance use issues, they get thrown around a lot. They get they have to make one appointment with a therapist in one place, and then their psychiatrist is another person who wants to also see them in person, and then their substance use counselor is somewhere else, and then they just get thrown around a lot. So this is an integrated program that provides all those things in one place, including case management. And that's case management not only for your healthcare needs, but also case management for your functional needs, including your school, like helping with your IEPs and 504s at school. So it's the one-stop shop for kids who have problematic use of substance. Here are some resources for you guys to follow, and you will get this in the form of a PDF at the end of the presentation, so you no need to like jot it down like right now. But these are some helpful resources that you can use for teenagers in your own practice settings. And this is the point where we are going to take like a short break, like maybe let's say 5 minutes or like 4 minutes. Let's do 4 minutes. If anyone needs to go to the bathroom, drink. One question that came up, that was with regards to prescription of N-acetylcysteine. You can write, as a physician, you can write a prescription for N-acetylcysteine, but it is super expensive from the pharmacies. I do not recommend that. Like I generally tell them to buy it from Amazon. It's like $15 would get you like a 3-month supply for that. One thing to keep in mind while you're ordering from Amazon or recommending it is to make sure it is a mono product. So N-acetylcysteine, because it's a supplement, it comes in with sometimes mixed with like other products, like other supplements like micronutrients like molybdenum and stuff. And the dose at which you're getting the N-acetylcysteine or NAC is going to make you take way more molybdenum that you should be taking. So always get just the mono product of N-acetylcysteine. There are some brand recommendations that I give to my patients, which I can share with you guys like separately. I don't want it to be part of the CME like presentations. Just I have no financial interest with them either, but I just don't want to like take any like brand names here. But yeah, so it's a super cheap product. So if it's costing you more than like 15, $20, like you should not be buying that. If you get it from the pharmacy, it's like $300 or something. One of the things that I would like tell you is like when you're giving someone an acetylcysteine is that it tastes really bad, like really, really bad. And it comes in the form of capsules, but even then, like, you have those, like the smell of it is horrible. So like tell them to take it with some sort of like, strong smelling or tasting food, like juices or something like that. Otherwise, they're gonna take it for 2 days and stop taking it afterwards. I have tasted it myself just to make sure I know what they were talking about. Okay, so with that in mind, we can actually move on to part number 2. I didn't see any other questions in the chat box, like, but if there are any, please let me know and I'll be more than happy to answer them. So part 2 of the presentation is more about what is brief intervention, like what is like, SBIRT, first of all. We in the mental health, like, spheres, we hear this word a lot. And I think if you don't know it, you should know about it. Like it's a public health intervention. It's a model that was created, which is called screening, brief intervention, and then referral to treatment. It's just an acronym for that. And this was developed by SAMHSA. It's supposed to be a comprehensive public health model, which means it's supposed to be easy to implement. It's supposed um, to be an intervention that doesn't take a lot of like, training and education to begin with, right? And it is based on the principles of motivational interviewing or motivational enhancement therapy that we've already talked about briefly. And then part of SBIRT that I think you have to learn a little bit is called, first of all, the spelling of SBIRT in my slide is incorrect, so I am so sorry for that. It's not SIBRT, it's SBIRT. But anyways, I'm sorry about that. But for brief intervention, like that's the only part that you need to learn, because screening should be universal and there are validated screening tools out there that you can use. There are some validated models for brief intervention, but the evidence is not like, like it's not like, like one and done kind of thing. Like this is the way to do it and that's the only way to do it. And then referral to treatment doesn't need to be like evidence-based, just you're referring to someone, right? Who you think is like, a little higher risk, right? So we're going to talk a little bit about all these things. So how does SBIRT, like, workflow looks like? So you screen universally, and the idea behind screening universally is to make it less stigmatizing, right? Because if you there's two things. Actually, first of all, they did a study on that for physicians. I don't know if they've done a similar study for like mental health professionals, but they looked at like, how much your clinical gestalt or like, your medical knowledge, like, predicts if like how well can you predict if someone has like um, um, a substance use disorder, alcohol or otherwise, right? And the result showed actually not very effectively. Like it's almost like a coin toss. Like they were only 50% correct, like only correct 50% of the time. So you should not go by your clinical gestalt. There should be clinical screenings, and the screening needs to be universal because you want to destigmatize the issue. You want to normalize it. You want to normalize that conversation. Because if you only talk to a few people which you think that have a problem, they're going to be like, why are you asking me this question, right? And they feel stigmatized. Uh, but you want to just ask everyone, every adolescent that comes to your clinic, every so often, you need to ask them, like you need to screen them for substance use, right? And there are a bunch of like validated tools out there. Audit is one of those ones. For adolescents specifically, Craft is one of them. And then one of the screening tools that I really like, it's not mentioned here, and there's a good resource slide at the end of it. You're gonna find all these tools at the end in the resource slide. But one of the tools I really like is called S2BI. It's actually one of the shortest screening tools. It's like literally 3 or 4 questions in there. And again, short is important because it's easy to integrate, it's easy to implement. So it's the shortest screening tool out there, and it is validated, which means it does produce good results, right, in terms of screening. And the idea behind screening is to categorize the individuals into low risk, intermediate risk, or high risk categories. And brief intervention is just like, any intervention that you provide. It can be super short, and it says 15 to 30 minutes. Is actually like, some of the brief intervention models out there, they have interventions as short as like 3 minutes for brief intervention, right? So it can be like very short. And then referral to treatment is for high risk individual. You just like want to send them to higher level of care, whether it's in the form of like evaluation through a specialist, or it's in the form of sending them to detox or residential level of care. So how does SBIRT work? So universal screening, in the blue square, you can see like, you brief questionnaire. It can be during the interview, like, the initial intake. It can be at the time when they're checking in for the appointment. It can be before they see you on their own. It can be self-administered, like, on an iPad or something like that. But like universally screening them is screening everyone. And then you risk categorize based on the answers. If they are just low risk, the brief intervention just means like handing them off some pamphlets about like how substance use in this age group is like, deleterious to their like mental health, to their physical health. And then if they are moderate risk category, that's the part where you do brief interventions in the form of motivational interviewing, at least some semblance of follow-up with the same provider. And then for the high risk individual, it's easy. You just refer them to specialized care. Question is, we do all these things. We do in healthcare, we do a lot of things, and we don't even know if it works or not, right? So let's see if it works. So in the case of screening and brief intervention, when we look at alcohol use, so there is this recent meta-analysis. Again, meta-analyses are strong studies because these are studies of studies. So they look at the evidence on a certain topic and they collate all the evidence that's available, and they distill it down to one outcome. Like, so in this meta-analysis that was performed for the USPSTF, that's a long acronym, which means the United States Preventative Services Task Force. I remember that still. Okay, USPSTF. So that's what it was performed for. And they looked at 68 different trials, and 11 of these trials were on pregnant women, some of these trials for adolescents. And what they found out was that NNT is numbers needed to treat, which is if you perform this particular intervention in X number of people, then you find one positive outcome, right? So the NNT, or numbers needed to treat, to lower the drinking risk or reduce people from high risk drinking or like binge drinking or drinking a lot, to low risk drinking, where like they were drinking within what is the specified limits, the RDA limits for alcohol. It was 7, which means you needed to just perform this intervention, this brief intervention, which I said it can be super short, as short as 3 minutes. You just need to perform it on 7 individuals for you to have a positive outcome in one of the individuals. So that's an effective way to actually deal with it, right? And it is particularly effective in individuals who are non-dependent on alcohol, which means they have like a problematic use of alcohol. They're using a lot of alcohol, but they still have not developed a use disorder with alcohol. When we look at the effectiveness of these things for like other substances, when it's cannabis or all these other substances that we talk about, the evidence is not quite there. So they did do a meta-analysis in there. There were only 29 trials compared to 68 trials for the for alcohol use. And they did find that there was decreased binge drinking associated with it, and that was only limited to females. There was better service utilization, again, only limited to females. There was no real change in like nicotine, cannabis, or other drug consumption, and no change in mental health symptoms. That doesn't mean it's not effective. It just means we just don't have enough strong evidence to support that effectiveness, right? We're still like, trying to form the right interventions for these different substances. But alcohol is one of the oldest substances. The intervention for alcohol is one of the oldest ones. So that's been studied well, and it's been shown to be effective. So we do assume that they will be effective against these other substances as well. So again, talking about brief intervention, when we look at this risk triangle, this is the part where the brief intervention is the most effective, right? Where they are moderate risk, they're not really substance use disorder people, so they don't really need to go to a specialist for an evaluation or long-term treatment, or they don't need to go to higher level of care. But their risk, their use pattern is such that it does put them at higher risk of having bad physical outcomes or eventually developing a substance use disorder in the future. That's the part where you'll do brief interventions. And there are all these different like frameworks of brief intervention. And one thing, and I'll talk about some of them like, as we go along, but you will notice one thing. They are all very similar because they're trying to achieve the same result. It's just like different ways of like, holding your ear. You can hold it from here, or you can like, go hold it from here. But most of these things are pretty similar. So the frames model is where you provide feedback, you impress upon them that it is like, responsibility. So you tell them that you have agency over your decisions, and because you have agency over your decision, it is also your responsibility. The outcomes are also your responsibility. You do give them some advice with regards to what they can you do to improve their substance use patterns. You give them a menu of options, right? So it's not like, you got to do this, or or there's no other better option, right? You give them all these different options, and sometimes, and definitely one of the menu options should just be associated with harm reduction. You don't always have to like, right away jump to abstinence for everyone. One of the menu options can just be, okay, let's work on just using clean needles for your substance to begin with, right? And then we can move on to other things. Or let's just focus on like getting you access to Narcan first, and then we'll talk about all these other things in the future. And that's important because you have to meet the patient where they are at that time. And the only people who can recover from substance use disorders are people who are alive, right? So if they're not alive, they can't recover. So the first step is to keep them alive long enough that they can recover. And then provide them with empathy, lots and lots of empathy, and self-efficacy, as it's similar in terms of responsibility, that they need to feel like they are in control and they are responsible for their outcomes because they have agency over their actions, right? Because one of the things that they feel is that they have this loss of control when they become like, addicted to substances, and they want to exert that control in the clinical setting when they come to you. So it's okay for them to exert control, and it's okay for you to impress upon them that yes, you do have control, you do have agency over your actions, but that also comes with you being responsible for your for the outcomes that are associated with those actions. The second technique is motivational interviewing. We've talked about it, motivational enhancement therapy, which is enhance their readiness to change by just reflective listening and affirmation. So you just listen to them and find out their own motivations to change, right? There is the 5A model, which is you ask them what the issue is, you give them advice, you assess change over time, you assist them with that change, and then you arrange for options for them. These are just like different acronyms. People love, like in healthcare, people love acronyms, like, but by and large, all of these are similar things. Assist is actually one of those things I really would want you to read up more on. And I do have the link to the Assist directory at the end of in the resource page. And this is a tool that was developed by WHO, and WHO is in the business of developing simplified tools that can be easily implemented, right? So it's a simplified tool of just implementing the SBIRT framework, and it has the tool for screening. It has like, the charts on how do you risk categorize people, and what is the specifics of brief intervention that you need to do, and at what point you need to refer them out for specialized treatment, right? And then Teen Intervene is one specific tool that's for adolescents, right? So we're going to talk a little bit about motivational enhancement therapy. I did talk about it in the previous part as well, but like the principle of motivational enhancement therapy or motivational interviewing is to include empathetic learning. So you listen more, talk less, right? Ask open-ended questions, right? Limit the suggestions you're giving to them to a minimum, and they need to trust you. express empathy, and then the last part, which is the most important, is to roll with resistance. Do not try to, push change. Like in this, what you want to do is you want them to be the change agent. You want them to find the motivation for change within themselves, because that's usually the more sustainable model of change. The frames model, as we talked a little bit earlier, is like, you provide them feedback that is personally relevant to them. So when you're talking to adolescents, quote them studies that talk about adolescents, right? Show them evidence that, why adolescents are particularly at risk, as compared to just giving them general evidence, like, general recommendations. Oh, drugs are bad for you. Second is responsibility. Acknowledge that the patient has a responsibility for their behavior and they have control over their actions. Give them advice, and the advice has to have two parts to it. Always give them advice that is objective, right? It shouldn't be like hand wavy. It should be like, this is what the evidence suggests. And sometimes for some people, they need prescriptive advice because they need some structure in their life and they're just looking for something to latch on to. That's a little different than motivational enhancement therapy, where you're not trying to prescribe them anything, you're trying to find their motivation. But for some individuals, prescriptive advice is super helpful, because then it gives them a guide way as to, like, okay, so you've told me, like, on Wednesday I'm going to do this, on Thursday I'm going to do this, on Friday I'm going to do this. And that just, like, kick starts their change. And in the beginning, sometimes prescriptive advice can be helpful. Give them a menu of options, as we talked about, and the menu should include at least one harm reduction option in there. Show them empathy. Empathy is the name of the game when it comes to substance use disorders, because these people, society has stigmatized them, their families have stigmatized them. Sometimes they're self-stigmatized. No one has, but they themselves, like, feel this guilt of, like, stigma, right? So you need to, like, do away with the stigma. So empathy is very important. And then, like, inculcate them in them the concept of self-efficacy, and make them verbalize some of these affirmations about self-efficacy, that they do have control over their actions, they do have control over the outcomes of those actions. Um, so there are some considerations in the primary care setting when you're doing SBIRT or when you're doing brief intervention. These considerations stem from the needs of primary care. The needs of primary care are that, like, you're dealing with 10,000 different issues in each patient, and mental health is just one of them, and substance use is just a subset of one of them, right? So you cannot have, like, these detailed sessions that I have the luxury of doing with my patients, right? So for the primary care setting, you need a tool that is quick, that can be integrated into the workflow, and sometimes, like, the provider doesn't have to do it, and it's either self-administered or it can be done at check-in by the check-in staff or something like that, right? So that's one of the needs. So integrate your behavioral interventions into routine visits and integrate the screenings within the EHR system, and sometimes they should be self-administered, right? And the pro tip is that, one another consideration for primary care setting is that they also are limiting what they can do based on what they can be compensated for. So I just want to tell everyone that screening for substance use disorders is something you can get compensated for, and providing brief intervention is something you can get compensated for. So you can use these CPT codes for compensation in the primary care setting if you need to use them, right? So it's 99408, which is if you provide them any brief intervention for 15 to 30 minutes, and 99409 for greater than 30 minutes in length, right? So they do reimburse very well for these codes, so use them if you want to. In the mental health care settings, there are what are some considerations? Using validated screening tools. Again, as I said, do not use clinical gestalt. Do not use your, like, clinical acumen. Use validated screening tools, please. Validated tools, even though they seem, like, weird, like the way they're worded and everything, but they have tested them out on, like, many a patients, and they seem to work, and we know their efficacy. We know how well they work. So please use them. And introduce substance use conversations in a non-judgmental manner. That's very important. As I said, like, these people are most of the time self-stigmatized. So you need to introduce these discussions very non-judgmentally and by the way kind of thing. We do this for everyone. Like, start off with, like, we do these screenings for everyone. They might be worded a little weird, but I gotta ask them the way they are because that's the only way they work well. So that's how I start like some of these screening tools, or like, when I used to start them when I was in primary care. So use motivational enhancement or motivational interviewing techniques during your therapy. So open-ended questions, affirmations, reflections, and summaries. And then develop a plan with them. Like, just don't like provide an intervention and, like, it's not like a one and done kind of situation. You did the brief intervention, you've done your part, now it's up to them. No, follow up on it, like, so that they feel like, uh, you are invested in it as much, and you are focused on it, and they have some accountability and they will be asked next time about it. So it's important to form a plan and then like have some follow up in that. And then the frequency of intervention should just be tailored around like how much they are ready to change. If it's a high risk substance that they're using that puts them at higher risk, like frequency probably should be more, and the discussion should more be around harm reduction. And if it's a low risk substance that doesn't have any immediate danger to their physical or mental well-being, then it can be more focused around like, making these long-term plans with them, and starting off with like, incremental change only. And what are some challenges? What are some solutions? So time constraint is a challenge. How do you deal with time constraint? Use team-based workflows. So basically, you don't need to do everything on your own, right? Maybe the screening can be self-administered. Maybe the screening can be done by the front desk staff before the patient even sees you. So utilize other people in your team. Utilize the patients themselves, right? For these screening tools. Because if you're doing everything, you don't have time for the actual thing that you want to do with the patient, which is like, therapy for therapists and for primary care clinicians dealing with all their like chronic diseases, right? The second thing is stigma and fear of punishment. It's like especially pronounced in the perinatal age, perinatal time period, because like, there's this risk that the child is going to be taken away from them. Or it is also pronounced actually in the adolescent age group, because there's a lot of other like privileges that these individuals are afforded that might be taken away because of their use, right? So you have to really normalize the conversation about substance use. You need to do universal screening, and that's the best way to normalize the conversation. If your first sentence is, we do it for everyone. So I'm just asking you these things because we ask everyone. They are a little weirdly worded, but please bear with me while I ask you these questions. It just like destigmatizes the conversation, normalizes it for them that, it's not just me they're asking. They probably ask everyone, and probably like many people say yes to these things, right? And then say that, like, and you will not scandalize me by anything you say. You cannot tell me anything that I've not heard before, right? So sentences like that can go a long way. And then the third thing is limited access to follow-up treatment. So build partnerships, like, like know what resources you have in your local area. Like, if you're in San Antonio, for adolescents, you have Rise Recovery, you have Cicada, and you have Beeville, Texas, which is like, our integrated program. So you have a bunch of resources. It's just that most of the times we don't know what resources are available to us. So spend some time, like, and like find yourself resources that are around you that you can rely on. Even if you can't follow them up regularly, there is someone who can, and you probably need to just refer them to that resource who can like regularly follow up and provide the level of care that is needed by this patient. So take home points for this particular topic are: brief interventions are evidence-based for alcohol, and there is emerging evidence for other drugs as well. So please use them. SBIRT is a scalable model. It's a public health model, which means it's easy to integrate. And I have some resources for you that you can use to integrate SBIRT into your daily practices. That's going to be in the next slide. And there are multiple brief intervention models out there. Choose one that works for your setting, right? I talked about the frames framework. I talked about the motivational interviewing framework. I talked about the WHO toolkit. So whichever works better for your population, for your workflow, use that. There's multiple to choose from. And one thing to keep in mind is, even though these are meant to be easy to implement, but again, even easy things have some upfront cost associated with it, which means, like, there might be some changes to the workflow that are required for integrating these screenings in there. There might be some training as to what do you do for brief interventions. And there's usually not a lot, but there is, if you do it like once, it will pay dividends like long term for your patients and for your practice. So in terms of some resources, there's an SBIRT resource by the Office of Addiction Services and Support. That's a national resource. And the other one that I really want you all to follow is the Assist Linked Brief Intervention toolkit that WHO has developed. And that's the second link that's on this resource page. And you will get access to these resource pages and the rest of the presentation, so you can follow them along. I thank you all for just bearing with me through this long presentation. I want to ask if anyone has any questions. I'm actually going to close the presentation so that I can look at some questions in the chat
There are
box, if
about
there
2
are any.
questions in the chat box right now, that are there. But please, if you all have other questions, just throw them in the chat box and we'll just go through them.
Okay. Oh yeah, a lot of people have tasted NAC in here, which is amazing. That's good. Is there any
Dr.
differences
Shadari,
in suggest? Yes, sir.
I actually do primary care. It sounds like you did it beforehand.
Yes, I am. My background is in family medicine, so yes, I did a lot of primary care.
I mean, you put forward codes for kind of billing and that kind of stuff for these interventions, but realistically, when I have patients scheduled, I have patients scheduled, and there ain't no gaps.
Yeah. So the question is about like time management in this situation. Is that correct?
Yes.
Okay, so when you are doing all these things, so for example, the reimbursement codes for these things, it can include like the time that they spend on their screening, right? So the screening might be done by your nursing staff or the MA, and you can include that time, and then the 3 or 5 minutes of counseling that you did on them that totals up to 15 minutes or something. You can add that 99408 code for that.
I would think giving them more than trying to shoot for 30 minutes or whatever would be more beneficial to them. I just don't know how to work it other than to kind of push patients down the.
Yeah, and that's why I think you're absolutely right. Again, I cannot fix like the primary care system with these codes. These are they're just like little bit nuggets of incentives that are in there for primary care clinicians. Like if they can find some time to do these things, if you feel like someone really needs more than what you can allot them, just know that there are resources out there, right? So for example, I can tell you about San Antonio. I know a little bit about local resources. So we have Rise Recovery, which they don't have providers, they don't have healthcare providers, but they have a very strong network of uh, uh, peer coaches and family support groups, and a lot of other ancillary services that are provided to the patients. They also have summer programs they run. They also run like a recovery high school and all sorts of things. And then you have like the Bevel, Texas here in San Antonio, which is the integrated adolescent substance use program, which includes like case management and then mental health care if they need like care, psychiatric care for their co-occurring substance use disorder. All these things are integrated into one place. So that's there. So if you cannot find the time and you feel like they need more time than you can give them, you should refer them for this particular aspect of their care to specialized services.
It's
The B-Well, just to, sorry to cut you off, like the B-Well program is actually hopefully soon going to be a regional program. So we are going to be able to see people all across Texas. That has not yet operationalized because we want to make sure that we do provide like care locally to our San Antonio residents first. But hopefully within the next couple of months, we will have the Be Well Adolescent program accessible to everyone across Texas.
bringing them back in a week or so does that, if they come back, obviously, sometimes they obviously won't come back, but if they come
It's not a
back,
bad, yeah, it's
does
not a
that
bad
usually have the
idea.
same benefit?
Yes, yes, it's not a bad idea. So what you need to ideally you should you should integrate it within if you wanna call them back in a week for discussing their lab results, for example, right? You can integrate discussing or providing brief intervention in that visit, because lab results don't take a lot of time or a lot of explaining, right?
Right.
If you wanna bring them back, for example, for their blood pressure check because their BMI was high and their blood pressure came out above the 99th percentile or something like that, you want to call them back for a blood pressure check, then you can also integrate the brief intervention with that visit. So the idea is to try to integrate it within existing workflows as opposed to just doing specialized visits for these things, because then it becomes difficult, right? Then it becomes difficult for a primary care provider to have specialized visit for this, and then a specialized visit for their obesity, and a specialized visit for their hormonal issues. So if you can lump some of these together, it might be more helpful.
Thank you. Very good.
I do want to call out a few questions in the chat box just because of time. Um, there's a question that says, are there any differences in suggestions for harm reduction for adolescents than for adults?
That's a good question, I think. Thank you so much for asking. I think it was Michelle, right? Thank you for asking this question. I think the North Star for you should be the earlier you intervene on these individuals, the greater difference you can make in their life. So because I also see adults, for substance use disorder, the goals that I have for my adults are so much more focused on harm reduction, because at that stage of their life, if I'm seeing a 45-year-old with a 15-20 year history of use, my aim for them is to make sure that they're not getting any physical harm from their substances, right? I cannot reverse back time and get them into high school where they can get into a professional college, right? Which they wanted to be, if they wanted to be a veterinarian, I can't make them a veterinarian when they're 60 years of age. Well, they can if they want to, but I'm just saying it's difficult, right? But when you're talking to adolescents, the amount of change you can make in that age group is very significant, right? So yes, our approach is more towards complete functional recovery. I'm not talking about abstinence only. I'm talking about complete functional recovery. So addressing all their functional needs is very important, right? Because if the use of cannabis is impacting their ability to play football, and their football was their ticket to going to college, then that can be a hook for you to use for trying to get them away from their cannabis use or whatever they're using at that time, right? But for harm reduction, if you feel like someone is at that stage, at that serious stage, if they're for example, if they're injecting substances, no matter if they're adults or adolescents or whoever they are, right? If they are doing that, the first thing you need to make sure is they don't die from an overdose. So they need to have Narcan on them. They need to know about what test shots are. They need to know how to use clean needles and disposable needles every time, and where they can get clean needles from. Those are the first things you teach them first, right? And then you can talk about moving forward, uh, how do you reduce use? How do you reduce use to a less harmful kind of use, moving from IV to smoking and stuff like that. But yes, the steps for harm reduction are the same depending on the severity of the use pattern. One thing in particular for harm reduction in teenagers is that they don't understand this thing, is that they oftentimes have an overdose for substances they are not addicted to. And that's very important, especially with opioids. This has been happening because they use this. They're gonna go to a party. They're gonna have this party pill, and if a person who's addicted to opioids and heroin and fentanyl long term, that small dose of heroin in that pressed pill will not kill them. And people who are who have opioid use disorders, they come to me and they tell me that they use these pressed pills when they can't get access to real fentanyl or real heroin, and they don't die of an overdose. But a kid who has never, who's completely naive to opioids before, if they take a pressed pill, they don't have a tolerance to opioids, they can have an overdose, right? So just imparting that knowledge is part of harm reduction, where any pill that you're not getting directly from a pharmacy is potentially a pressed pill and can potentially have like fentanyl in there or other opioids in there or other things that you don't know what's in there and can cause an overdose. And you are at higher risk because you don't have a use disorder, which means you do not have tolerance, right? That sort of counseling is important for teenagers.
Before we go to the last question, I just want to bring people's attention to the chat box. The evaluation link has been placed there. And so again, if you're seeking CME or CEU credit, you do need to complete that fully. So I just want you to make sure you click on that before we close the Zoom here in a little bit, so you can be filling that out. And even if, again, if you don't need credit, we still want your feedback so we can know how to improve these in the future. So the last question here, I don't know if you can see it, Dr. Chaudhary, regarding the
Yeah,
brain
yeah.
activate. Okay.
Yes, yeah. So thank you so much, Servando, for your question. And the question, I'll read it out. So with regards to brain activation research that I showed in this presentation, there was a difference in the level of activation in 14-year-olds versus 20 years old. And like, how does that translate into like, the functioning of the brain and emotional well-being and cognitive performance and all these other symptoms. So I'm actually uh, I can share my screen one more time. The idea that I wanted to really like, put across there. Yeah, can everyone see my screen again? Yes, I'll
Yes.
take that as, yeah, okay, perfect. So what I really wanted to show here, like the 16-year-olds, like, the non-drinker slide is just there to give you a reference point to see what part of the brain should activate for a certain activity, right? So because they were testing spatial memory, these were the parts of the brain that were activating in the non-drinker brain, right? And in the heavy drinker brain, which means they only have 2 years of heavy drinking at the age of 16, it shows that the same parts of the brain light up, but they're lighting up more than they light up in non-drinkers, which means that the brain is trying to compensate for the anatomic damage that the alcohol has caused, right? So whatever damage has been caused, it's not going to translate into any outward symptoms right now because the brain is able to compensate for that. There is anatomical damage, but the brain is compensating by activating the damaged parts a little more than they should have activated in a normal brain, right? But then if you continue using at the same level, so now you have 5-year history of heavy drinking, and these are 20-year-old individuals. What you see is, again, the non-drinker slide is only for reference. It shows the parts of the brain that should normally activate by doing this task, right? Now you don't have that same level of activation anymore. And what that means is that the anatomical damage that has been going on over time, it's come to a point where just physiologically activating the brain more wouldn't compensate for it anymore, right? So like, if you have like a bunch of wires going around and then 2 or 3 wires, like they get broken off and then there's still one wire dangling around, you can transmit more current through that wire. But if all the wires are cut, there's no current that can pass through those wires anymore, right? In the same way, in this 20-year-old with 5 years of drinking, you can see that the parts of the brain, the parts of the brain that should be lit up are not lighting up anymore because the brain cannot compensate for that anatomical damage that chronic heavy alcohol use has caused, right? And especially because we're testing spatial memory, this is looking at the amygdala. So the parts of the brain that are not lighting up, those are the parts of the brain where the amygdala sits, and the amygdala is associated with like spatial memory, but especially with memory in general, like, for memory formation and memory processing. So in the long run, heavy drinkers do have bad like, worse off memory than people who do not drink alcohol. If that answers, that's a long answer to your short question. I'm sorry.
All right.
Uh,
There's one follow-up question. How are they defining heavy use? Someone just, April just typed.
yeah, that's a good question. I actually probably have written it down. Um, I have it in my slide, so I'm gonna pull up the slide.
And yes, we'll be wrapping up shortly. So yes, I know it is now 4:01.
Okay.
If you do
Okay.
need to head out, feel free. But I'll let you answer the final question of the amounts before we close today.
I'm so sorry. Like, it's not off the top of my head and I couldn't find it. I would assume it's more than the RDA, so it's like more than 14 standard drinks in a week for males. But I might be incorrect on that, but I have the reference slide, like the reference study in there in my slide. So you can always go back to the study and see what how they defined as heavy drinking. I'm sorry, I don't have that off the top of my head.
Wonderful. Well, again, I just want to give a virtual round of applause to you, Dr. Chaudhary, for this workshop today. You've given us valuable information. And again, thank you so much for your presentation. Thank you all for attending today. Please, again, fill out the survey. That way we can also send you the slides. So we'll use the email address you give us in the evaluations to send you the slides. So thank you for being here. Have a wonderful rest of your day. Take care, everybody. Bye-bye.